Welcome everyone to our BJJ podcast for the month of May. I'm Andrew Duckworth and a warm welcome from your team here at the Bone and Joint Journal. As always, we'd like to start by thanking all of you for your continued comments and support, as well as a big thanks to our many authors and colleagues who have taken part. We hope that you're continuing to enjoy our podcast and all the knowledge translation work we're delivering from your team here at the Journal. Our podcasts continue to focus on papers published each month here at the BJJ, as well as our special edition podcast series. That includes our Insights from the US series, along with our Specialty Editors series with our invaluable specialty editors here at the Journal, both of which we are continuing this year. So today for our monthly podcast, I have the pleasure of being joined by three authors from a paper published in this month's edition of the BJJ entitled Robotic Arm-Assisted versus Manual Unicompartmental Knee Arthroplasty, a systematic review and meta-analysis of the Mako robotic system. So firstly, I'm very pleased to be joined by Mr. Nick Clement, who is a fellow editorial board member here at the BJJ and one of my great colleagues and friends here in Edinburgh. Thanks for joining us, Nick. It's great to have you with us.
Brilliant. Thanks for inviting me back, Andrew. I didn't think you'd invite me back after last time.
Secondly, me and Nick have the pleasure of being joined by one of our great colleagues from the West, Mr. Mark Blythe from Glasgow. Mark, great to have you with us today.
Yeah, delighted to be here. Thank you for having me.
And rounding off our lineup, lastly, but certainly not least, we are delighted to welcome back our great editor-in-chief here at the BJJ, Professor Haddad. Prof, it's great to have you back.
Andrew, thank you for having me and thank you for doing this.
So I thought we'd kick off, guys, with yourself, Prof, if that's all right. I thought you maybe could give us a brief overview of your experience so far with robotic knee replacements and how you feel the literature has sort of evolved and developed over the past few years.
Yeah, thanks. It's really been a fascinating area which has grown exponentially and looks like it really is here to stay. So certainly from a London and England setting, my experience of the current systems, if you like, of Mako dates back to 2016 when we got the first clinical system in the UK, which after Mark's research system which he's had in Glasgow and done some very nice research with. So we've got now 5.5 years of experience with it, starting with the uni and then adopting the total knee and increasingly using the total hip with the modern software. It's been a fascinating learning curve in terms of understanding the power of this technology and quite what it can deliver in terms of the three-dimensional planning, in terms of understanding individualized targets, and in terms of being able to execute them. And I think the literature's basically paralleled my experience. It's been initially started with studies focused on accuracy and precision and the ability to hit it. Then there were sort of short-term clinical studies looking at the perioperative pathway, early patient outcomes, patient recoveries, the pain response, the need for fewer opiates than standard procedures. So documenting some signals. And as we've gone along, the studies have increased in number and become more sophisticated. So now we're seeing more granular patient-based outcomes. We're seeing longer term outcomes, both clinically and radiographically. We are, I can tell you in the background, starting to see 5-year proms. We're starting to see some registry data, and we're starting to see the randomized studies beyond the excellent Mark Blythe studies starting to report, including one of our own pilot studies that we published in the journal last year, but the others now closing to recruitment. And we've also seen some bigger studies start to recruit, like the RACER study. So I think the literature here is becoming richer for this one device. And I think it's important to stress that the robotic explosion goes beyond this one device. It's really the whole enhanced technology field is growing, but each device needs its own data, its own evidence, and its own literature. And certainly for this one particular device, the Mako, we've seen an explosion of interest and a great deal of data now.
Yeah, absolutely, Prof. And like you say, it's very important to say that this is very much on the Mako robotic system we're going to be talking about for this paper. But like you say, it's so important that each of the systems have their own evidence and have their own build-up of literature. But I agree with you, like a lot of maybe potentially false dawns that we see in our field, where something exciting comes along, but actually it doesn't stay all the evidence and support it. This really has just kicked on, hasn't it? Really.
I mean, it's been incredibly impressive. I mean, I think it's interesting because we saw navigation come and to a certain extent go. And I think there is a difference in parallel here in that we're looking more three-dimensionally and we're starting to understand the target. Yeah. And particularly in the knee, that may be the big change that's happening, and that we're recognizing the target that we're chasing may not be the target we chased before.
Yeah, absolutely. And Mark, if I could come to you next, we all know you've, as Prof has alluded to, a huge amount of literature in this area with some excellent RCTs. You've done many which are published in the journal. Can you give us your take on a similar question to Prof on the current evidence in robotic knee replacement, how that's mirrored your own experience as well?
So, Andrew, I think the evidence base is growing, although, if we're being really critical, robotic systems have been around in orthopedics for the last 30 years, and it's been a pretty slow burn. And it is actually said that there are more review articles written about robotic systems than actual articles on original research, which is a bit damning, really.
Yeah. A
lot of the original studies were done, of course, on the original fully autonomous systems, showed relatively high complication rates, particularly with the soft tissues. And I think the experience more recently with these semi-active systems, which we really focused on in this paper, are probably much more relevant to modern practice. The data that we've got on unicompartmental knees, I think, is much more mature. The Mako system was developed and became available for clinical use in 2008. But it wasn't really until it was acquired by Stryker that it became widely available for use with total knee replacement. So that total knee replacement data is definitely not nearly as mature. So I think it is developing. It's really been very interesting to see the results of all the different studies that have been coming through. I think the only thing I'd say about the evidence from the literature, and as we look at it, is we always have to be mindful with these new technologies about the risk of bias. We're all invested in this as surgeons, as the nurses and physios, the porters, the managers, industry, but especially the patients we all want this to work. And that might affect the way that we report how our knee feels, or how we interpret the results of the studies and the data that we are presented with. So I think we always need to be careful that we look and we search out for bias in case we feel that there are perhaps undeserved benefits from this technology. But very exciting to see the data that's coming through now.
No, I think that's a really interesting point, Mark, like you say about bias, and even like you say from the patient point of view, in that certainly if you say to a patient you're going to get a robotic knee, there's probably already a bias there that they're going to get something a bit shinier and a bit better, and that's a really interesting point, isn't it, about how they interpret it afterwards?
Yeah, and I think it's interesting because that bias, I think, has evolved. So we embarked on our first unicompartmental knee study probably back in 2010 was our first recruited patient, and actually there was quite a lot of suspicion around at that time. And you fast forward 5 years or plus to the more recent studies, and patients are definitely would look at that technology as providing them benefits. So patients are certainly not in equipoise, and we need to be really careful, even in our randomized control trial type studies, that we try and maintain that blinding where possible, and really look for protecting the studies from bias.
Absolutely. And Mark, just before I move on to the paper, just for those who are not familiar with it, you mentioned the type of system. So the Mako is in contrast to some other systems, is a semi-active system. So that allows the surgeon sort of interact with the robot during the bone preparation, alignment, and knee balancing. Is that correct?
Yeah, so it's under surgeon control throughout the whole process, and what the robot does is create this haptic, this boundary based on the preoperative plan, beyond which it's impossible for you to cut. It provides a physical resistance, and also gives you some audible clues as well when you're at the edge of the boundary, and will eventually shut down if you push it beyond those boundaries. So very much under surgeon control, whereas these fully autonomous systems originally, you could take your hands off and the robot would do all of the milling for you, and much more difficult therefore to control from a safety perspective.
Yeah, that's really interesting. So Nick, if I come to you, can you sort of give us a brief introduction, Nick, to the paper itself, and maybe some background on the current systematic reviews that are out there, and what made you look at this?
Yes, I'd just like to try and defend the review after Mark's comments there that there's more reviews than papers. This is obviously the best review, of course, and sets the mark for others. So this review really came on the back of a paper that we all 2019-ish, when I was just learning about robotic surgery. I haven't done any on a patient just yet. I've done a few on the cadavers, but I'm still just looking at the evidence rather than doing the surgery myself. And we amalgamated all different types of robots, semi-automated, and put all the results together. But Prof, mentioned at that time when we did that review is that there's obviously different robots out there, and obviously the more reading that we've done, we then looked at the recent systematic reviews that are out there, and everybody's done the same sort of thing, just put them all together, see what comes out the other end. So we first did this for total knees, looking at the robotic arm assisted, i.e. the Mako image-based system compared with gold standard being manual. And then we looked at total hip that was published last year in the journal. And then we moved on to looking at the unicompartmental knee. That was the only paper actually I didn't actually show a functional difference. So that was the aim, really, just to have a like for like comparison rather than a homogeneous robotic.
Yeah, no, that makes sense. And would you, in terms of the quality of the literature, when you look at sort of total knee, uni knee, and hip, is which one would you say has the best quality of evidence currently?
Well, Mark Blythe has obviously published his randomized trial 4, and that's a high quality study, but there's lots, as Prof said at the very beginning, there's lots coming through now. The RACER study, which is total knees, and RACER 2, total hips. So there's a lot more data coming out now, and Prof's own studies I'm sure will be coming out shortly.
Yeah, absolutely. So, Nick, if we just move on to the methods of the paper, I thought we'd talk about this just very briefly. I don't want to take us away from time for discussion, but can you just maybe give us a quick overview of how the paper was set up, the review was set up, and what studies you included?
There wasn't enough randomized controlled trials, sadly, because there was only Mark's 4 times. So we included level 2 and level 3 studies, only robotic arm assisted, and any study that was reporting learning curve, implant alignment, functional outcome, complications, and cost, because we thought those were kind of the main 5 outcomes. And they were collected by 2 fellows that were with us at the time. And we did all the work. Junren Zhang, who's the main author, and Nathan Ong. So got to thank them for all their work.
Absolutely. And just before we move on to the results, Nick, in terms of the outcome measures, the problems particularly, that varied in what was reported, and it wasn't reported in all, was it? Is that correct?
Well, so that wasn't reported in them all. Those that obviously followed proms up reported different proms. So like some had the Oxford score, some had the Knee Society score in, some had the WOMAC in, all at different time points. Sometimes there weren't. There was different variations on that score reported, so it was very difficult to put them together. So we just reported on the WOMAC and the Knee Society score. One option would have been to convert all the scores to 0 to 100 and then just put them all together. But we thought that was a bit, maybe it's not perfect.
Okay.
So we reported on the main 2 outcomes being the WOMAC and the Knee Society score.
Brilliant. Okay. So if we move on to the results, Nick, there were 179 articles were identified from the initial screening, 14 were included eventually. So of the 14, one reported on learning curve, 5 on implant positioning, 6 on outcomes, 5 on complications, 6 on survivorship, and 3 on cost. And of the type of studies, 4 were from the same randomized trial, which you've mentioned. 2 were Markov decision cost economic analyses, and 3 were retrospective, and 5 being retrospective. So in terms of the main findings, could you sort of summarize what you found with regards learning curve and implant alignment?
I think the learning curve is fascinating because it's the same for the total knee as well. I can't remember for the hip off the top of my head, sadly, but the learning curve for position is 0, which I find is fascinating. Like so, even if you're starting to learn, like if I don't do unicompartmental knees, but if I did, I'd have a learning curve of 25, 50.
Yeah,
would probably cause, well, I wouldn't be optimal. Well, with this, your learning curve is 0 for implant positioning. Obviously, I'll take a bit like I do anyway. And even for operating room staff confidence, that was around 6 cases. And I'm almost sure now that you can apply Mako to total knees and unicompartmental. Those 6 cases are probably going to be spread between the 2, I would have thought. So all of a sudden, after a week, you're probably going to be flying.
Yeah, no, it's really interesting. I thought that was the start thing, like you say, when you compare it to the manual uni as well, it's quite remarkable, isn't it? And in terms of sort of what about the functional outcomes reported? We've mentioned them, but what did they show, and what about complications?
There was no difference in functional outcomes, and Mark showed no difference in his, but he did show a ceiling effect. I can't remember the exact number now, Mark. You have to keep me right. I'm sure you presented the Oxford score was something like, I think it was like 30% had a maximum score. No, that's right. The score within the MCID of the maximum score. That's what it was. So about a third of patients had that. So whether we're using the wrong scoring system and we just don't have something sensitive enough yet. I know some people have used the Forgotten John score, less of a ceiling effect, but anyway, there was no difference in functional outcome. But the main difference that you mentioned about the complications there, but within the complications, there was reoperations.
Yeah.
And there was no difference between deep infection, superficial infection, and reoperation. But when you put them all together, the overall rate of complications, being all those things together, were higher.
Yeah.
And within that group, we also looked. Also, there was one registry study, because obviously you can't include registry data in a systematic review because it ain't on PubMed or anyway, But there was an Australian registry study that showed I think it was about 0.7 versus 3% revision rate around about 2 years between robotics and manual unis. So that's certainly given the hint that there's the improved accuracy. It might not be shown in functional outcomes, but it might be shown in improved survivorship.
Yeah, absolutely. So Nick, I think sort of drawing that all together, what do you feel are the take-home messages of the study? But I suppose caveating it with any limitations you felt that were of the data.
I think, as Mark says, there's a massive bias for anything else than a randomized trial, isn't there? When a patient knows that they're already going to get a make, or it would be nice to do that study, I suppose. I don't know whether Mark's got that data to ask what knee you thought you had and whether their outcomes are better depending on what they thought they might have had. I don't know whether that would be quite nice. Anyway, but I think that's certainly a big thing. And I think the racer coming from the total knee side of things would be brilliant to let us know whether, hopefully it's all blinded, to see whether there is a real difference with robotic surgery. But when you speak to more surgeons, because as I said before, I don't do this, but when surgeons see these patients post-operatively, they all say it's having fantastic outcomes, good. But again, whether that's bias of their own, I don't know.
Yeah, absolutely. And would it be fair to say, Nick, as well, a lot of these studies, in the grand scheme of things, are still relatively short-term follow-up compared to what we need, or would that be harsh?
And Mark's the longest at was 5 years. I don't know what you're coming up to 10 now, Mark, probably. So 5. He's probably showing 5 and probably going up to 10 year follow-up. But it would be nice to have larger cohorts, I suppose, with maybe different proms. But
yeah, absolutely. So, Prof, if I could come back to you, what's your take on this? How do you feel this adds to the current data? And what's your experience with particularly that data about the learning curve in the context of your own experiences with robotic surgery?
No, thanks. And I think the learning curve is the most interesting thing here in some respects, and because we've looked at it within our own unit for total hip, for uni, and for total knee, and you hit the target from case 1, but the learning is all about the team, as Nick said. It's all about time. It's really, and it'll be different for different people, because if you've navigated, then your learning curve is going to be a lot shorter in terms of time and putting pins in and so on. So I think that's really going to be interesting, because we will also get better at teaching this. Yeah. So I think the learning curve doesn't seem to be harming patients, and that's really reassuring. And that's certainly been our experience. It's been easy to educate people in it. Trainees come in, they love it, they learn a lot from it. And that's something I think the literature hasn't yet possibly articulated, is what a phenomenal teaching tool it is to be able to plan something in 3 dimensions and then execute it and think about it. So that sort of cognitive work that takes place is a critical part of training in knee surgery, which is quite important.
Yeah, that's really interesting, Prof, isn't it? The idea that it can maybe improve your understanding of what you're trying to do. So it's that's really interesting.
And we shouldn't get away from the fact that we probably still don't know exactly what the target is. We still don't know what the proper balance of the knee is. There's a long journey that we're going on here. Yeah. My suspicion is that where this paper sits is it gives us enough of a signal that this is a good journey to be on, and that we need to look beyond. It's fascinating for me. Randomized studies are great, and we must do them, and we are doing them, and Mark's done some great ones. But the problem is Mark's a superb surgeon. So actually Mark's manual unis probably are way better than everybody else's, and hence for him to detect a signal may be quite hard. Whereas, take it out into the masses, bring something that reduces the error, get Clement doing it, for God's sake, and then you may see a fairly dramatic signal. And that'd be, on the other hand, you may not, because there's a bit of cognitive work that goes, some decision making to do. So there really is an unknown here as to how this is going to translate. But this is a stepping stone looking at the data from enthusiasts, from big centers that are doing it. And then over the next 5 to 10 years, we're going to see longer term data, but we're also going to see more pragmatic data as, you know, the registries really start to pick this up.
Yeah, no, I think that's the interesting thing, is actually when it spreads to the masses, like you say, and you get the data from everybody, then that's really the test, isn't it? Mark, if I come to you, then you know, what are your thoughts as well into, you know, similar question to that of Pross, but also, you know, it was interesting reading about, you know, the big reduction in fewer alignment outliers with the robotic surgery and complications. Is that your experience with it as well? And do you think that's where the benefit of this lies in the longer term, do you think?
Yeah, I think that's absolutely right. I mean, that's the one thing we've got a real clear signal across all of the studies that have been done, that it's much more accurate at delivering that preoperative surgical plan. And the pre-op surgical plan is probably best worked out for unis, because really what are we trying to do? We're trying to reconstitute that constitutional alignment by retensioning the ligament on the involved side of the joint. And maybe there's a little bit of work to do on what the coronal alignment is of the tibial component, but everything else is really a resurfacing procedure. I think the pre-op surgical plan, as far as is suggested, is really not that well worked out for the total knee replacements. And so we've got this reproducibility and precision that we can perhaps use to then define what that target is, whether it is mechanical axis restricted or fully kinematic, or this functional alignment that's being done now, which is a kind of hybrid between kinematic and mechanical axis alignment. And so I think that's certainly the way ahead. But that's going to require a lot of data and a lot of experience over time. But I think the other thing we can do is to use that safety that we're demonstrating with it, the lower complication rate, and perhaps it really will be of advantage to people who are not low volume surgeons, because we're hopefully sort of gradually eliminating those, but perhaps people in early years of their career, to give them a little bit more confidence to do the procedure with a little bit more safety.
Yeah, no, absolutely, Mark. I think that's a nice summary of those potential benefits and how we can move forward. I thought maybe I'd finish off asking a question to all of you, which is the same, and sort of maybe being devil's advocate a bit. But given the equivalent findings, you know, with regards PROMs and reintervention infection, will robotic knee replacement ever be cost effective in the NHS setting? Maybe I'll start with yourself with that question.
That's a very good question. Cost effective, it depends on what you mean by cost effective. So cost effective from a cost utility point of view is difficult. We're just working with Mark currently on his data using the EQ5D. In the recent paper that he published, there was no difference in the EQ5D. So by definition, from a cost utility point of view, it's difficult, but there is that decreased revision risk potentially in the longer term, and the decreased complication risk. Return to theatre, in Mark's paper, there was, I can't remember off the top of my head, it's gone. I think there was one arthroscopy, maybe two, and one revision in the manual group. So all that mounts up, because those patients would have had scans, CTs, whatever else, been to the clinic a few times, seen the GP, went to theatre. So all that kind of cost mounts up, but whether that balances against the cost of a Mako procedure to prevent that morbidity within the NHS, I don't know. But I think certainly if it was a member of my family, I'd want a knee replacement that was probably done as accurately as possible. So probably going to maybe Mark or Prof to do them manually, but certainly in a normal setting, I just wonder whether accuracy has to be our golden aim or our gold standard. So I don't know whether it is a cost-effective thing or whether it's just best care.
Yeah, that's interesting. And what do you think, Prof? Do you think that's the take it'll go down?
I think, you know, the studies are being designed, including our studies, including RACER, to really look at that. In terms of the uni, intuitively, it is so the right thing to do to plan that way and balance it to the soft tissues. And if you look at the failure mode of unis, you know, we've touched the surface with this. We've had, you know, Mark's too good a surgeon, quite frankly, to have done that study. So the problem is the failure mode tend to be things like overcorrection, malposition, etc. So I think when we get into the longer term, when we get into wider application, I would imagine it'll be the enhanced technology of some form will be the way to do unis, because the error, it's too easy to get it wrong otherwise. That would be my view. But you're right, getting that data that's going to be a lot of work, and that's why these, sometimes we need more research.
No, absolutely, probably. That's an interesting take, isn't it? Like when you say, like you said before, if we do spread it, you spread it to the masses, everybody, and actually the money you will probably save potentially on revisions and other problems, it could all very easily add up in favour, couldn't it? Mark, if I come to you last, what do you think? You've done a lot of the research in this area. Do you think there will be a day when it will just be standard of care on the NHS?
Yeah, I think it's inevitable. And Faraz has made the point, I've heard him say this many times, that robots, once they're in industry, once they're there, they never go. Yeah. And I think that look, the costs will come down. I mean, it's the same with all new tech, they're expensive, and I think that the costs will come down over time. And particularly if you've got, wider applications of the technology, then you can use it in more situations. So the cost per case will come down. And maybe we're asking too much of it to think that we're going to see the clinical improvements just in the milling or bone cutting, and with the marginal gains that you'll get with other new technologies. So about ligament tension sensors, about augmented reality, AI, and all those sorts of things, which incrementally will improve the outcomes. Then we'll be able to justify those additional costs. One of the things that, if you look at it though, you can kind of turn costs in its head a little bit by saying, well, look, you get about 6 or 7 QALYs for a unicompartmental knee replacement. The additional cost for us in our study, on the basis that we were going to be doing 100 cases a year, which is pretty low volume for the use of a robot, was about £1,000 per case. And you kind of do the maths in your head, and that's about £130 per QALY. So given that, NICE will fund whatever it is, £30,000 per QALY, it's pretty small change, isn't it? So I think all we need to do is to demonstrate some benefit, and we get obsessed with it being a minimally important clinical difference in a PROM that we need to demonstrate, but we need to just demonstrate a societal benefit, and I think those costs will actually go down, and then they will become insignificant in the grand scheme of things.
I think that's a very true, Mark, and I think that's a really nice final note, actually, in terms of, like you say, I think it's the costs will come down eventually, like with all technology, as you say, and it will almost, as you say, probably become a fait accompli that that's what we need to do. Well, guys, I'm afraid that's all we have time for today, but thank you so much for taking time to join us, all of you, and congratulations on a great study and all the work that you've all done in this area. It was great to have you all with us, and I really enjoyed that. And to our listeners, we do hope you've enjoyed joining us, and we encourage you to share your thoughts and comments through social media and the like. Feel free to tweet or post about anything we've discussed here today, and thanks again for joining us. Take care, everyone.